Our next speaker is Felicia McKoy. Dr. McKoy completed her internal medicine residency at NYU Brooklyn campus. She did her nephrology fellowship at SUNY Downstate. At present, transplant nephrology fellow with us here in Downstate. She will also be starting her critical care fellowship in the next few months. Dr. McKoy will be speaking to us on hematological complications. In my view, hematological complication is the most common complication post-transplant. All my patients either have anemia, leukopenia, or thrombocytopenia. I have never seen any without any of these complications. I would like to invite Dr. McKoy to the podium. Welcome, Dr. McKoy.
Thank you so much, Dr. Naji. Thank you, everybody. Thank you, Dr. Rashan, Dr. Markel, for inviting me to talk. So I'll be discussing complications with hematological complications in renal transplant patients. So I'll start off with a case. This is a 44-year-old man who was seen in pre-transplant clinic. He has a history of hypertension, hyperlipidemia, developmental delay, hyperparathyroidism, asthma. And he did have a previous transplant in 1996 that failed in 2021, and he was restarted back on dialysis. So he was seen in our pre-transplant clinic in November of 2021, and he was sought to have no absolute or relative contraindication for the transplant surgery, and he was considered low to moderate risk. So in March of the following year, he was called in for a kidney. The procedure went well. As far as his immunosuppression, he was received induction therapy with thymoglobulin and solumedrol, and he was continued on maintenance therapy with tacrolimus, Celsep 1 gram BID, and prednisone. He was also given prophylaxis ID medication, which includes Bactrim to prevent PJP, Miselex for candidiasis, and Valsite for CMV infection. Throughout his hospital course, it was complicated by delayed graft function, which is requiring dialysis due to the allograft not functioning immediately. And he was discharged on intermittent dialysis Monday, Wednesday, and Friday. So the next slide goes over his labs, including his CBC. So it actually shows pre-transplant, his white count was between 2 and 3, which is pretty low. You could consider this leukopenia at the time of transplant. After transplant, which was in March of 2022, you can see a trend in his white count going down as low as 1.97 to even 0.56. And with the differential, he had an ANC of roughly around 300. And also you can see his hemoglobin was low. He did have anemia to start with, but it did drop to as low as 7.5. And his platelets was pretty much normal throughout. So this slide actually goes over our protocol for neutropenia. So with a white count less than 2.5, you want to obtain a differential of the CBC, and there you would find the absolute neutrophil count, the ANC. And we have either mild, moderate, or severe neutropenia. So anything less than 1,500, so 1,000 to 1,500, you would want to monitor the patient. If it's between 500 to 1,000, you would consider reducing your Celsep or MMF by 50%. And then less than 500, you would want to hold the medication completely and even start prednisone 5 milligrams daily. Usually all the patients are on at least 2 medication for immunosuppression. Then if it continues to be low, you would want to start Neupogen or Fulgastrim. And the dose that we use is 5 micrograms per kg. And we usually want to give at least 3 doses at a time. And you follow up with repeat CBC with differential within 3 to 7 days. And if it's above 500, you want to consider restarting back the CellCept and discontinuing the prednisone. Or if it's less than 500, you want to restart the Neupogen. So for our patient, he had his CellCept decrease by 50%. He went from 1 gram BID to 500 BID. And we also checked for CMV and BK virus. These are also culprits that can cause leukopenia. He did receive Neupogen, about 480 micrograms. He was actually admitted on June 10th, 2022 with neutropenia. His white count was 1.09, ANC was 0.6, and he did receive Neupogen. At the time, his CMV was negative, and we decided to actually space out his Bactrim, which can also contribute to it, to every other day from daily. And we discontinued his Valsite, which was, he was at the 3-month mark to have stopped it. Okay, he was discharged and then readmitted again later that month. His white count was still around 1, ANC was 0.56. He received Neupogen again. This time he did have a fever, so now it's Neupogen, neutropenic fever, and they started cefepime on him. CellCept was held, ID was called, and the workup for any infectious causes was negative. And we actually called hematology as well, and they contributed the neutropenia due to the medications. And it was advised to stop the Bactrim and also hold the CellCept. So later on that year, he did not get readmitted. So fast forward to this year in clinic, his white count went up. It improved to roughly around 2.8. His ANC was 1.9. Hemoglobin also improved to 13. And at this time, he's not on dialysis and his allograft is functioning very well. And the plan was to resume the CellCept to at a lower dose, 250 BID. So this table just gives an overview of some of the complications that it can occur in these patients. As far as pancytopenia, you want to look at some of the medications that is given in red. Usually the immunosuppressants such as azathioprine and thymoglobulin are some of the culprits, as well as MMF. As far as thrombocytopenia in blue, you look at your calcineurin inhibitors, also some of the antimicrobials like linezolid and antiviral agents such as ganciclovir and valganciclovir, which we use for our prophylaxis. Also, you want to look to see if the patient is infected, include CMV, EBV, parvovirus, and also any nutritional deficiencies such as folate, vitamin B12, zinc, and copper. So to go further in, as far as post-transplant anemia, there's 2 types. It can be acute versus chronic. Acute is within the first 6 months of transplant, and chronic is after the 6 months. And the incidence is pretty high, like Dr. Naji said, about 38%, and the reoccurrence within 5 years is about 48%. And the etiology is usually the allograft not functioning at the time, and usually the EPO level is very low. Also contributing is the medications such as the immunosuppression, antiviral medications, and or if the patient is infected or have nutritional deficiencies, as I stated before. Also, some complication that can occur is post-transplant erythrocytosis, and this is the opposite of anemia. You will see hemoglobin as high as 17 or more than 17, and usually this occurs in later on in the transplant, more than 6 months. And with increased hemoglobin, it will lead to increased viscosity of the blood, causing thrombosis, hypertension, and even a stroke. The incidence for PTE is about 10 to 20%, and this is actually contributed to overproduction of epogen. And the studies show that it's likely due to angiotensin II or chronic rejection, hydronephrosis, renal artery stenosis, or even cyclosporin. And the treatment for that is a RAS inhibitor, such as ACE or ARBs. Next, going on with the cytopenias, which is any of the cells that are down, including leukopenia or neutropenia. You have an incidence of roughly 20 to 63% in this population. Leukopenia is defined as a white count less than 3 to 4,000. Neutropenia, anything below 1,500. Again, it could be mild, moderate, or severe, as low as 500. And the medication, again, you're looking at your immunosuppression, including Cellcept, Valcyte for antivirals, cyclosporin, azathioprine, and the treatment is either discontinuing or reducing the offending agent, and you want to use Neupogen if it's severe. Next is thrombocytopenia. This is defined as platelets less than 50,000. And this is usually seen again in the first year of transplant. And you can see platelets as low in the initial 3 months after transplant, and the manifestation, you see bleeding, bruising, petechiae, or even fatigue. And the etiology, again, there's an overlap. Again, you're looking at your immunosuppression, infection, and vitamin deficiencies. And also use of specifically thymoglobulin, which the patient did receive, also known as the rabbit anti-thymocyte globulin. Next, other complications includes PTLD, which is post-transplant lymphoproliferative disorder, and the incidence is lower than the cytopenias, which is 1 to 5%. And this is caused by EBV infection. And you will see that the EBV will infect the B cells and cause lymphoid hyperplasia or even B cell lymphoma. And the treatment is to taper back on your immunosuppression therapy. Also, you can have something called HPS or hemophagocytic syndrome. And here you would have proliferation of the macrophages that ingest some of the blood cells. And this will lead to some opportunist infections. So some of the manifestations would be fever, cytopenia, and you would most likely see this in the first few months. And this is considered very deadly, associated with 53% of death. And last, I would talk about TMA, or thrombotic microangiopathy, which is a group of disorders characterized by thrombocytopenia, intravascular hemolysis, presence of schistocytes, purpura, thrombi, and neurological symptoms, fever, and renal dysfunction. TMA is associated with CNIs and graft failure, and it's CNI is considered directly toxic to the microvascular endothelial cells, and which can actually induce vasoconstriction and platelet aggregation. And the treatment for TMA is fresh frozen plasma and plasmapheresis. And my last slide just goes over the management of the post-transplant blood disorders. We usually focus on tapering immunosuppression and recognizing and treating any infections such as viral, bacterial, or opportunist infections, and just restoring back the bone marrow function, whether reducing the therapy or even improving the kidney graft function survival itself. Thank you.
Thank you, Dr. McKoy. That was a great presentation.